Hello, my name is Wipaporn Natalie, and I'll be speaking today about prevention of STIs and HIV in youth in the Asia-Pacific region. In the next 20 minutes, I'll be discussing where our numbers on HIV and STIs are in the Asia-Pacific region in youth, what the current ongoing major challenges are, what we've learned so far from initiatives tried, and we'll finish off with future directions. A decade back, the Asia-Pacific region was seeing 100,000 new HIV infections in young people each year, which dropped to 82,000 in 2018. In order to end AIDS by 2030, the UNAIDS set a target of no more than 25,000 new infections in 2020, a challenging figure given the trajectory of previous figures seen. Like the state of new HIV infections globally, youth in the Asia-Pacific region are disproportionately affected by new HIV infections, so in other words, represent a smaller proportion of those living with HIV, which in 2018 was only 7% compared to the proportion they contributed to all new infections, which in 2018 was a striking 1/4. Asia-Pacific's HIV epidemic is also different from that seen in Africa, where the HIV epidemic is a more generalized one, with high disease burden seen in adolescent girls, whereas the bar graphs on the bottom of this slide you can see that the majority of cases in the Asia-Pacific region are men, mostly made up of new cases of men who have sex with men and transgender women. Therefore, it's become necessary to focus resources and operations to reach out to and care for these populations, which are currently in their early stages of implementation. So where are countries in the Asia-Pacific region with the highest burden of new HIV infections in youth? In those who published data on this in 2018, the top 6 countries included Indonesia, the Philippines, Myanmar, Pakistan, Thailand, and Malaysia. This data from the Ceylon Community Clinic in Bangkok by the Thai-US CDC collaboration shows high incidence rates in young MSM and transgender women, which clearly shows younger MSM being most affected by new HIV infections of 10 per 100 person years, well above the WHO threshold of 3 used to recommend PrEP rollout, highlighting the strong need in this population for PrEP use in order to curb HIV transmission. This data, also from a study by the Thailand-US CDC collaboration where HIV at-risk young people were screened for STIs, displays high prevalence and incidence of HIV and STIs, highlighting the need for screening of STIs where possible when testing for HIV. In particular, HIV and syphilis, which are both diagnosed with blood-based testing, could be routinely done together. Although it would clearly be beneficial to also screen for chlamydia and gonorrhea in high-risk adolescents, the reality is in most low-middle-income settings that the cost of this is quite prohibitive in practice, and the 2 potential directions this could take in the near future is number 1, use of low-cost point-of-care testing, or number 2, use of post-exposure prophylaxis or PEP, which has been tried using doxycycline, both promising strategies currently under investigation, with the impact of PEP on antimicrobial resistance awaited to inform future practice guidelines on this challenge. As PrEP in the Asia-Pacific region is being scaled up, an interesting question to consider is how does STI prevalence in those who are at risk of HIV compared to those living with HIV? Data collected by Bangkok's IHRI has found high STI figures in youth, with numbers seen in youth living with HIV to be double of those seen in youth at risk of HIV, and substantial incidence has been seen in those who are asymptomatic, as seen in the bottom table in the slide, again emphasizing the need for routine STI testing with affordable nucleic acid amplification testing to be done in those living with HIV or HIV at-risk populations at intervals, as syndromic-based treatment is unlikely to sufficiently manage STIs in this population, particularly as it's well known that infections at sites other than the urethra, such as anal, pharyngeal, or vaginal, are frequently not symptomatic. Most of us are familiar with global HIV targets, but for STI global targets, this may be a less familiar one that I want to highlight in this talk, which for 2030, the WHO has set goals of 90% reductions in syphilis, 90% reductions in gonorrhea, and also 90% HPV vaccine coverage in countries that deliver the HPV vaccine in their national immunization programs, which of course we know is a major preventable STI. You might be asking yourself, given how difficult adolescents can be to deal with, why bother with STI and HIV prevention in this age group? Well, we know that STIs and HIV affect youth disproportionately, as mentioned earlier in this talk. They're readily preventable and treatable conditions and can have lasting consequences if undiagnosed and untreated, including issues with onward transmission, fertility issues, and increased cancer risk. A major challenge with the difficulty of prevention of STIs and HIV in adolescents is the multiple factors that can influence risk, including individual factors such as sexual practices, skills, ability and willingness in managing their own sexual health, and of course a major part of adolescent life is relationships, how these youth are managing power dynamics and communicating to keep themselves safe, and of course regarding the community the young person is a part of will also influence their level of risk of getting STIs and/or HIV. If we look at the data on levels of comprehensive knowledge on HIV in our region, you can see that the majority of countries, less than half of their youth, are knowledgeable on HIV, pointing out a major need for capacity building in youth to be able to take charge of their own sexual health. As mentioned previously, relationship navigation forms a major part of how young people can tackle their STI risk, and making a point of supporting couples as much as you can, rather than just individuals, supporting individuals to inform their partners after diagnosis, and also rapid treatment to prevent reinfection form cornerstones of STI care for young people. Another major point is the challenge to put into practice, particularly in low-income settings, is ensuring young service users are given as much privacy and respect as possible, as this hugely influences their health-seeking behaviours. As we saw in the figures discussed earlier in this talk, PrEP service delivery and HIV prevention and STI screening and treatment are really best friends that go hand in hand, as they're so often seen together. The reluctance of many practitioners to start PrEP in youth due to fears of sexual risk behavioral decompensation when PrEP first came out was completely understandable. However, in practice, we've seen that it's really, if anything, an opportunity to reach at-risk populations to provide comprehensive adolescent care services such as mental health, contraception, and substance addiction care to complement the HIV protection provided by PrEP. Affordable point-of-care STI testing has been recognized by the World Health Organization as a major barrier to STI control and prevention, and is an exciting area of active research currently in many countries. You may remember from an earlier slide I showed that the 13 to 18-year-old age group has the highest HIV incidence in Thailand. If this was the case in your country, do you think that they should be able to access PrEP and STI care independently for under 18s? Of course, being below the legal age of consent in most countries, being under 18 forms a major concern many service providers understandably have in working with young people. This is a fantastic study done in the Philippines, in Iloilo City, by the Family Planning Organization of the Philippines. It was piloted between 2016 and 2018 on proxy consent for HIV testing for 15 to 17-year-olds, so in other words, enabling them to consent to testing without the need for parental consent, and integration of adolescent sexual and reproductive health and HIV prevention to increase their access to these much-needed services to address a country in which has Asia's fastest growing HIV epidemics. With the support of multiple government and non-government agencies, this pilot that looked at the safety and feasibility of lowering proxy consent age for HIV testing was instrumental in lobbying for the lowering of the age of consent of HIV testing in the Philippines, and has led to youth 15 and above in the Philippines now able to access HIV testing without parental consent, an amazing example of how feasibility studies of alternatives to current systemic barriers in accessing services can ultimately produce grassroots-level results for adolescent service users. Dr. Lee Pen-sun presented this wonderful news at the 2020 Asia-Pacific virtual discussion held last month that PrEP has now been rolled out in Cambodia. And here you can see that the prevalence of HIV in their young population, the graph on the left showing prevalences between 1 to 3% in young MSM, and substantially higher prevalences in young transgender women, up to 8%. Although PrEP is available to youth in Cambodia, the legal requirement for youth to have parental consent to access PrEP has meant that so far, although uptake nationally of PrEP continues to increase, as you can see on the graph on the left here, the most HIV at-risk populations in their country, young transgender women, as we saw in the previous slide, have very limited access to PrEP, as is the case with young transgender men, represented in the bars in light green at the bottom of the bars. This is unfortunately the reality in many countries in our region, and I really want to encourage everyone to continue to collect feasibility and safety data in serving these high-risk younger populations to increase this much-needed access in the way of HIV proxy testing was done for 15 to 17-year-olds in the Philippines. At our center at Chulalongkorn University in Bangkok, in conjunction with IHRI, we started providing PrEP to young people between 2017 and 2018, and we now have approximately 400 adolescents in our care, the vast majority of which are MSM and transgender women, with 80% being older adolescents between 18 and 24 years. With the PrEP initiation carried out in youth we did between 2018 and 19, we also carried out a study in 200 adolescent young MSM and transgender women aged between 15 to 19 who were at risk of HIV and provided them with PrEP for 6 months. We learned that despite providing differentiated youth care, service user behaviors and needs were still very different between our biggest service users, with transgender women preferring to attend clinics in large groups and have the support of peers when making decisions on their health, whereas most MSM seem to prefer to seek care individually and make decisions independently. During this trial, we measured PrEP adherence at months 3 and 6 and used tenofovir diphosphate, or TVFDP, as a blood level measure to look at PrEP adherence, using the standard cutoff of 700 femtomoles per punch to define excellent adherence, a figure which you will see again on the next slide. This bar chart shows levels of measured PrEP adherence using tenofovir diphosphate levels in the trial we did, with month of intervention in the x-axis and percentage of those adherent in the y-axis. The black bars across the top show the total proportions with excellent adherence to PrEP, which you can see made up approximately half of all youth PrEP users. What is interesting in this study was that despite imperfect PrEP adherence, no seroconversions were seen, an encouraging outcome that is in keeping with Habera's concept of prevention-effective adherence when measuring PrEP use success in preventing HIV infection as part of a dynamic package of other alternative prevention strategies rather than focusing on perfect PrEP adherence alone. You might then wonder whether this population study was truly at HIV risk, given that nobody seroconverted. But as you'll see in the following slide, where I'll talk about what happened following the initial 6 months of the study during the COVID-19 outbreak, 7 cases who discontinued PrEP actually did seroconvert, producing an incidence of 15.7 per 100 person years, well above the threshold of the 3 used by the WHO to recommend PrEP. Following the first 6 months of follow-up, where adolescents were followed up monthly, follow-up changed to quarterly, where we saw a large drop in retention from 73 to 20% between months 12 to 24. This chart displaying the 7 cases that seroconverted during this time were all cases that self-reported stopping PrEP, 6 were MSM and 1 transgender woman, all were aged between 18 to 21 years. The green bars represent measured excellent PrEP adherence, yellow moderate adherence, and white poor adherence. The solid lines self-reported adherence and dotted lines self-reported non-adherence. Green circles represented their last HIV negative test and red circles when seroconversion was detected. Median seroconversion time was 6 months. The key take-home message from this slide is that enabling PrEP persistence after their initiation for the entire duration of their at-risk period in adolescence, which we've seen so far can be a number of years, is crucial in keeping them HIV-free and ensuring regular engagement is done, whether in person or through online or telephone means, are key in ensuring that they stay safe, a particularly important lesson we have learned during the COVID epidemic, with major travel restrictions in place. Of course, another major concern many had when PrEP first came out was with protection against HIV it offered, whether condom use would reduce as a result. Our study found that self-reported condom use of 34% at baseline increased to over 50% at both months 3 and 6, emphasizing the importance of pairing PrEP provision with risk reduction counseling, condom and lubricant provision. In recent years, many HIV self-test trials have looked at the feasibility and acceptability of using them as practical solutions in scaling up testing in HIV at at-risk populations, including adolescents, but to our knowledge, few have specifically looked at this in Asia-Pacific youth. This study, done in Bangkok in 15 to 19-year-olds, found the HIV self-test to be feasible and acceptable in youth. However, a major challenge seen was that a quarter of all tests turned out to be invalid due to missteps taken during carrying out the test, emphasizing the need for supervisory support in ensuring valid test results for young users. With 80% of study participants expressing their preference to have medical facility-based testing, we've utilized self-testing as a rapid point of care HIV test in clinics to speed up service times and also to enable us to spend more time providing support and counseling to service users. COVID-related travel restrictions have also given us the opportunity to post PrEP and HIV self-tests to young people, which has been very helpful in enabling continuation of HIV service provision. Although we are still in the middle of the COVID pandemic and all its challenges, I think the silver lining to this has been that it's truly been an opportunity to develop remote medical services to overcome health facility accessibility issues, whether using telehealth and also triaging people who needs to come in and who can be managed through postal and online services, which has included self-screening tests, posting medication to patients, and regardless of when the COVID-19 situation improves, the logistical improvements made for service users during this time would mean that kept in place, there is potential for the capacity of medical facilities to increase the numbers of clients in which they can take care of, which is great news for adolescent care scale-up. Another wonderful example of work being done to engage youth in HIV and STI knowledge is being done in Taiwan by a partnership between the Persons with HIV/AIDS Rights Advocacy Association of Taiwan and Life Education Studio, a social enterprise. They've jointly produced board games as an engaging way of stimulating open discussion on HIV, such as PrEP and what the window period is. Finally, it's important to remember that there are many new and innovative biomedical interventions that could potentially be used to support increased access to testing and adolescent care service linkage and improvement to overall sexual health services. Rapid tests for STIs and HIV have potential to increase accessibility of youth to testing. The HPV vaccine is now available for scale-up, and in the future we could be seeing use of the meningococcal vaccine, which has been observed so far to provide some cross-protection with gonorrhea, a subject of currently ongoing clinical trials. Dosing and regimen options have also expanded with on-demand PrEP available to youth who may prefer to use this option if they are having less frequent sex to minimize medication fatigue. And there's also less frequent dosing options available with intramuscular cabotegravir and oral islatravir, which will also soon become available in the near future, that will be less subject to the limitations of adherence issues of daily dosing, and additionally tenofovir alafenamide or TAF that hopefully will become more accessible for use as PrEP in youth who stand to benefit from the lesser potential bone mineral density side effects at a stage where they are accruing their peak bone masses. I really hope this talk has been useful for you in thinking about the need for our region to really push the agenda for youth to be included in HIV and STI prevention, because they're disproportionately affected by HIV, with differentiated services needed for their age group and also the lifting of legal barriers really needed. Care for adolescents needs to be provided as a package of one-stop shop services as much as possible that can include education, condom provision, STI care, and PrEP provision. I would like to challenge you all that PrEP rollout and scale up in the Asia-Pacific region is really needed if we are to end the global AIDS epidemic by 2030. Thank you so much for your attention.